a lovely spring, May 21st outside. Welcome everyone for joining us for another improvised Zoom conference, but I think these educational conferences have really been great, and I appreciate everyone who's participated and prepared. Juggling a lot of different things, I know it's been a challenge, but hopefully people have found opportunity to join us and gain some knowledge. I just want to tell you that as we're winding down the Zoom schedule, or at least the COVID Zoom schedule, tomorrow we have the privilege of hearing one of our rising third-year fellows, Mike, to talk about the importance of pollution in cardiovascular disease. People may have been reading about how important, from a health point of view, general health point of view, and particularly cardiovascular health, has been impacted by COVID. One of the important things, the salutary effects, have been the fact that pollution, air pollution, has gone down, which may be one of the reasons that cardiac disease and acute events as well may have gone down. Mike is going to enlighten us about that and tell us about some of his work that he's going to do in the field. Just to tell you that next week, Monday is a holiday. Obviously, the hospital is open, but we won't have a Zoom conference. On next Tuesday, the 25th, there's the usual M&M for cardiology. Dr. Moreno is going to run that, and if there isn't that much, we'd love to hear clinical cases as well. Wednesday, Dr. Sean Pinney is going to talk to us about heart failure at Mount Sinai, past, present, and future. And on May 28th, which is sort of our last COVID conferences, I've really put aside for people as a wellness. What I would like people to do is to contribute their thoughts on how their life will be changed because of COVID, where physicians, nurse practitioners, healthcare givers, it's extremely important to realize that this is a seminal event, almost existential event for so many people. And I'd love to hear, and I think we would all benefit by hearing how this COVID has impacted people emotionally, their families' lives, not just their medical lives. And that's going to, I think, give wellness and strength to all of us. Today's conference is actually part 2 of imaging. And before I introduce Dr. Lerakis, I just want to acknowledge 2 people who have really been instrumental in keeping cardiology running, particularly in imaging. That's Dr. Kinney in the cath lab, who's kept the cath lab open. When people talk about phase 3, phase 4, we've been running in the cath lab. The patients have not been that great, though they're building every day. But all through the COVID time, the cath lab was open. Greg Serrao was doing procedures if needed. And also in the echo lab. There hasn't been a single day that echoes haven't been done under the leadership of Lori Croft and her very able team, and Samantha Buckley. I want to acknowledge them particularly as we're talking about imaging today. It's really privileged to have Dr. Lerakis lead the conference today. He's professor of medicine and director of non-invasive cardiology and director of imaging for structural and valve intervention for Mount Sinai system. He's been a pioneer in guidance of interventional procedures going back many years, is a respected leader in the field. Though he originally hails from Greece and went to medical school in Athens, he actually did nuclear cardiology here at Mount Sinai, subsequently trained at Presbyterian in Philadelphia, as well as in critical care in Brown, and then subsequently cardiology at Texas, and then faculty at Emory, from which Dr. Fuster, Dr. Sharma, and Dr. Dengus were able to lure him here. So without really further ado, Dr. Lerakis, thank you very much for moderating the conference today.
Thank you very much, Dr. Goldman, for this kind introduction. Everybody for joining us. Good morning, and this great conference. And, before I start, I know that COVID has tried to keep us apart each from another, but through the power of Zoom, we are actually as close together as ever. And it shows up today able to show 4 cases from all over the Mount Sinai Health System, and we'll start with hospital, Dr. Rajan, who works this case with Dr. Lori Croft, and I hope she can join us, and Dr. LaRocca. That will be the first case. Then we'll go to Mount Sinai Queens when Dr. Shaban will show us another case. Sorry for this, when we'll have a case from there, and then we'll finish with Mount Sinai Beth Israel, where also have a case from there. Also, we have a great panel, which will include, and I don't know what happened to the slides here, but it will be Dr. Chance, who is the, next slide. Who is the director of the CMR program here in Mount Sinai, and also Dr. Jacobi, Cardiothoracic Radiology and the director of the Cardiothoracic Imaging Fellowship. Without further to say, thank you very much for joining us, and I hope you enjoy the cases and you can interact during the presentations. So we'll start with the first case. Raya.
Yeah, thanks, Dr. Lerakis.
Please mute the phones if you're not speaking. Thank you.
I just want to make sure, are you able to see my screen?
Absolutely. Keep going.
Yes, we can see your slides. I believe, yep, we can see them.
Okay. Good morning, everyone. My name is Pragya Ranjan, and I'm one of the Advanced Cardiac Imaging Fellows at Mount Sinai. I'm sorry.
If you can speak louder, Praya.
Okay. Yeah, okay. Are you able to hear me now? Is this better?
Yes. Yes.
Okay. And today I'll be talking about multimodality cardiac imaging in the era of COVID-19 with the help of a case presentation. So a 54-year-old female presented to the ED with the chief complaints of subjective fevers, chills, nausea, vomiting, and right lower abdominal pain that had been ongoing for the past 2 days. She stated that the fevers had started a week earlier, and at that time, she had also had an associated mild cough. Her symptoms worsened 2 days prior to presentation. Her vitals in the ED were as follows. She was febrile with a temperature of 103, tachycardic with a heart rate of 120, had a respiratory rate of 20, and a blood pressure of 155 over 107. Her oxygen saturation was 97% on room air. Her past medical history was significant for non-obstructive coronary artery disease, hypertension, insulin-dependent diabetes, hyperlipidemia, obesity, and iron deficiency anemia. Home medications included baby aspirin, irbesartan, metformin, levothyroxine, rosuvastatin, and both long and short-acting insulin. She had no significant contributory social and family history, and her allergies included hydrocodone and ampicillin. Physical exam was relevant for altered mental status, dry mucous membranes, and tachycardia. So the initial concern in the ED was that she had an intra-abdominal infection, such as cholecystitis, cholangitis, pancreatitis, or pyelonephritis, and also that she could possibly have COVID-19 pneumonia given her prior symptoms of fever and cough. An EKG performed in the ED revealed normal sinus rhythm, and a portable chest X-ray demonstrated clear lung fields. Routine labs performed in the ED included a mild hyponatremia with a sodium of 131, mild hyperglycemia with a glucose of 225, mildly elevated alkaline phosphatase of 66, and mildly elevated LDH, D-dimer, and fibrinogen. The remainder of the labs, including a CBC, troponins, PT, PTT, INR, lactate, and urinalysis were all normal, and a CT head that was performed because of her mental status was also normal. However, a COVID PCR performed in the ED was positive. Because she had continued abdominal pain, a CT abdomen pelvis with intravenous contrast was performed, and this revealed a round mass in the left atrium and a sharply demarcated area of hypoenhancement of the left renal superior pole that was consistent with a renal infarct. There was no evidence of perinephric fat stranding, as would be expected in a patient with pyelonephritis. So the question was, what is the differential diagnosis of the left atrial mass? And the most common masses seen in the left atrium include thrombus, myxoma, lipoma, and then a number of malignant tumors such as fibrosarcoma, osteosarcoma, leiomyosarcoma, and undifferentiated sarcoma, as well as metastases. She was admitted to Mount Sinai, Queens for COVID-19 infection with an incidentally discovered left atrial mass and renal infarct. And treatment was initiated with hydroxychloroquine because of a concern for COVID-19 pneumonia. She was also started on an intravenous heparin drip because there was a concern that the left atrial mass could be a thrombus. And she was emergently transferred to Mount Sinai Hospital the following day for evaluation by CT surgery. Since the top two differentials of the mass were either a thrombus or a myxoma, we had to decide what imaging modality would best help differentiate the two. A transthoracic echocardiogram is often the initial imaging modality of choice because it's widely available and it helps to define both location and size as well as mobility of the mass. A TEE is currently considered a high-risk procedure because of the associated risk of aerosolization in COVID-19 patients. A cardiac CT is particularly useful in calcified masses and for the global assessment of chest and lung, but it does require patient transport and there is the risk of contrast-induced nephropathy as well as radiation exposure, and it does not have the same resolution as the CMR. A cardiac MRI has the additional advantage of accurate tissue characterization and high temporal resolution, but again, it's a long procedure. It can take up to 45 minutes, and breath holding is required. A number of professional imaging societies have outlined recommendations regarding performance of these tests during the pandemic. And in addition to reiterating the importance of using appropriate PPE and decontamination of rooms, they all emphasize the importance of performing these studies for urgent indications only. And they provide guidance on what these indications are and expect that each case be considered independently. We proceeded with a transthoracic echocardiogram. And on parasternal long axis view, a rounded mass was seen in the left atrium attached to the intraatrial septum. And this can be seen again here in the parasternal short axis. And in the zoomed in parasternal short axis view, the mass appears to have an irregular surface with frond-like projections. It can again be seen in the left atrium on the apical four-chamber view. And with contrast, it does not appear to enhance in the apical four-chamber view here. And these are still images of the same echo clip, so parasternal long axis, apical three-chamber, parasternal short axis, and a zoomed-in parasternal short axis view. And an X-plane across the mass in parasternal long axis with a parasternal short axis view. And based on the echocardiogram, the mass certainly seemed to be more consistent with a myxoma than a thrombus. However, we wanted to confirm this using an additional imaging modality. The decision was made not to perform a TEE because of the risk of COVID-19 transmission associated with the procedure. So as the next step, we considered a cardiac MRI. And again, the greatest advantage of a cardiac MRI is its ability to accurately perform tissue characterization of cardiac tumors and its high facial and temporal resolution. Additionally, it's able to differentiate thrombus from other cardiac tumors and can characterize cardiac tumors as being either benign or malignant. It's also fairly easy to identify a thrombus on a cardiac MRI, primarily because it's an avascular structure. So on images B, C, and D, B is an early gadolinium enhanced image and C and D are late gadolinium enhanced images. There's no contrast uptake seen, confirming that this is a thrombus in this example. So we proceeded with a cardiac MRI for our patient, and here on CTA imaging in the 4-chamber and the short axis view, we're again able to see a rounded mass in the left atrium attached to the intraatrial septum. There's no evidence of mitral valve obstruction, and overall the patient seems to have good cardiac function. And these are still images again demonstrating the mass in the left atrium attached to the intraatrial septum. On T1 weighted imaging, the mass appeared iso-intense as compared to the rest of the myocardium, which effectively rules out a lipoma, which can also be seen in this location, because on this sequence, a lipoma would appear hyper-intense or bright compared to the myocardium. And on T2 weighted imaging, in the 2-chamber and the 4-chamber view here, the mass appeared hyper-intense or brighter than the myocardium, which basically implied a fluid-rich tumor, as can be seen with the myxoma because it has high extracellular fluid content. On first pass perfusion imaging, there was mild enhancement of the mass seen here in the 2-chamber and the 4-chamber view. This effectively ruled out that it was a thrombus because an avascular structure like a thrombus should not enhance at all with perfusion imaging. Again, the 4-chamber and the 2-chamber view showing mild enhancement. And a thrombus is typically hypo-intense on long inversion times. However, this mass remained hyper-intense with both short and long inversion times. Again, this is not characteristic of a thrombus. And on late gadolinium enhancement imaging, there was a heterogeneous pattern of enhancement seen on both the 4 and the 2-chamber views. This is fairly consistent with a myxoma because myxomas are known to have heterogeneous surfaces with areas of cystic degeneration, necrosis, and hemorrhage. So we were able to conclude that the mass was likely a myxoma. It had characteristic echo features of a myxoma. It was located in the left atrium, had an irregular surface, it was attached to the intraatrial septum, and it did not cause any mitral valve prolapse, any mitral valve obstruction, although myxomas can cause that. And it had characteristic features of the myxoma on cardiac MRI as well. It was iso-intense on T1 weighted imaging. It was hyper-intense on T2 weighted imaging and had a heterogeneous pattern of enhancement on late gadolinium enhancement imaging. And so we were able to conclude the mass was likely a myxoma, it was not a thrombus, and we conveyed this to the CT surgery team. The CT surgery team chose to defer surgical resection for the myxoma until after complete resolution of the acute infection. And in the meanwhile, they recommended continuing short-term anticoagulation with apixaban, 5 milligram PO twice a day. Their rationale for doing this was twofold. Firstly, COVID-19 patients have a high predilection for thrombus formation, and our patients had already had a renal infarct and they wanted to prevent recurrent embolization. The patient remained stable during the hospitalization and she was discharged with the plan to perform surgery 4 to 6 weeks after discharge and after anticoagulation. There are some findings in the COVID literature that would be relevant in the context of this case that I just wanted to reference. There's sufficient evidence to suggest that there's a high incidence of arterial and venous thrombi in patients with COVID-19, and a number of papers have discussed the potential benefit of anticoagulation in these patients, including a recent paper from Mount Sinai that suggested a survival benefit in hospitalized COVID-19 patients with anticoagulation. And an expert consensus statement, which was published last month in JACC, actually outlines guidelines for prophylaxis and treatment of venous thromboembolism in these patients. And the authors actually go on to recommend anticoagulation prophylactically in certain high-risk patients after hospital discharge, patients with active cancer and with a prior history of VTE. And they recommend using DOACs or low molecular weight heparin. So I'd like to conclude by highlighting a couple of key points. Firstly, a myxoma should always be high in the differential for a left atrial mass, independent of COVID-19 infection. It has very characteristic features that help differentiate it from a thrombus, and a cardiac MRI is an excellent imaging modality to differentiate thrombus from any cardiac tumor. In our case, a multimodality imaging strategy was safely and appropriately utilized to make the diagnosis, despite the limitations secondary to the pandemic. And lastly, in routine myxoma cases, management is fairly straightforward and it involves early surgical resection. Anticoagulation is not typically recommended. However, in a patient with COVID-19 infection, which is known to be prothrombotic, the management becomes more challenging and it raises the following questions. Is short-term anticoagulation required at all? How long should the patient be anticoagulated for? Should low molecular weight heparin or a DOAC be chosen, and what dose of anticoagulation should be chosen? And when should surgery be performed? And with that, I will conclude the presentation portion of this talk and happy to move on to questions. Thank you.
Thank you, Pragya, for this great presentation. And I think what this case shows is that even during the COVID time, there are usual things. The patients can have other things than COVID, even if the myxoma in this case was the nitus for the most likely the thrombotic effect infarct that the patient had on the kidney. So we'll take a few questions. And also, before we take questions, we'd like to get the comments from Dr. Lerakis or Dr. Sanz, Dr. Jacobi about the imaging.
Excellent presentation, Pragya. Really nicely done. I think that it was a team effort. This patient came from Queens with the suspicion of a thrombus with a thromboembolic event. Dr. Croft did the transthoracic echo herself and gave the diagnosis of myxoma found on the characterizations of the echo, and then a recommendation for cardiac MRI if they wanted further tissue characterization to the team. And I think the cardiac MRI was just so nicely done in a very systematic, stepwise fashion to look for the tissue characterization, detailed the way Dr. Ranjan just explained. But it really gave a very nice display of how this myxoma took up the contrast and the late gadolinium enhancement in a very heterogeneous pattern that is just not seen in thrombus. So it just went along with a diagnosis of a tumor, and when putting everything together, myxoma was the highest differential.
Dr. Sanz, any comments? Dr. Jacobi?
Can you hear me? Can
Yes,
you hear me
yes.
now? Sorry.
Yes, Javier.
Oh,
yes.
sorry. Yeah, no, so excellent presentation, Pragya. I just wanted to make a couple of comments which are related to MRI in general, not specifically or necessarily to this case, for the evaluation of cardiac masses. So one thing is that although we prefer the patients to be able to breath hold, many of the things that we can do free breathing. So that's something important to know. If for whatever reason you think your patient is not going to be able to hold their breath or follow instructions, that shouldn't preclude us to be able to look at, to do an MRI and be able to look at the masses. And then in terms of the strengths and weaknesses in general of MRI for the evaluation of masses, so the most important strength, as Pragya and Dr. Lerakis just mentioned, is to be able to differentiate thrombus from tumor. That's over 95% accurate in the majority of the cases. And there are also some masses, like for example, a lipoma or a cyst, that are very easy to identify histologically. For the rest of the masses, MRI is not going to be able to tell you most of the times the specific histological diagnosis. Or it helps to differentiate benign from malignant masses from a number of features. But again, if you're expecting the MRI to tell you whether, for example, a sarcoma is a fibrosarcoma versus a liposarcoma, is going to be sometimes difficult. And then the weakness of the MRI also is for very small masses that are mobile. So sometimes we get requests for evaluation of things that could be vegetations or fibroblastomas. Things that are small, things that move a lot, we're not going to be able to see very well. So that's an important limitation that we should be all aware of.
Thank you, Javier, for these excellent points. Dr. Jacobi, about the CT, any comments?
No, that was excellent presentation. Thank you.
Okay.
Dr. Lerakis, can I just make a comment about echo contrast? Echo contrast have been increasing literature going back actually several years about using it as a perfusion agent looking at masses, the differentiating from thrombus from at least well-perfused masses in the heart. We do use it the same way looking at masses in the left atrial appendage during transesophageal echo, looking for filling defects or looking for perfusion of masses. But the key is looking at it at the start of the injection. It's very subtle because the masses don't have the same perfusion as the muscle. But if you start imaging, and the physician, or at least the sonographer, has to start recording from the beginning of the injection and probably 20 loops to look at the flow into the mass. It's very, sometimes it's very light flow, but it's denser than it was before the injection. And it's overwhelmed when it's in the left atrium because of the shadowing that occurs because of the density of the contrast in the LV cavity. You have to look at the wash in and then the wash out, and it should be denser than it was when it started. Tumors have neovascularization and not that many have hypervascularity, but many of them have a feeding vessel that sometimes you could see. So the key using contrast is not just injecting it and looking late in the injection, because it's hard to see left atrial masses because of the density of and the concentration. So you have to look at the wash in and the wash out curve, comparing it to baseline when you're using very low in mechanical index. So you have to use mechanical index 0.1, 0.2, not the normal mechanical index for contrast, let's say 0.3. Thank you.
Thank you, Dr. Gorman. Excellent points. From the 3D image that Dr. Croft obtained, it was very clear that the texture of that mass was most likely an myxoma and not a thrombus. For the interest of time, we will move to the next presentation. We'll go to Mount Sinai, Queens. Dr. Saban, if you can share your screen, please. Dr. Saban is the director of the preventive cardiology in Mount Sinai, Queens, as well as director of cardiovascular imaging. Nanda?
Yes, hello, I'm here. Can you hear me?
Yes.
Can you see my screen?
Yes.
Okay. I'd like to start by just thanking Dr. Lerakis for inviting us to present here today. It's our pleasure to be here. I'm going to start with a case presentation of a 20-year-old male whose only past medical history that was known to him was obesity, but he was diagnosed with pre-diabetes while he was in the hospital.
Mute their phones. Thank you.
Perhaps you can go to full slide mode.
Go ahead, please.
Under display settings on the top. There you go.
Thank you, Dr. Stone.
Please proceed.
Yes.
You may have gotten muted. You may need to unmute yourself.
Or the dog got hurt.
Nanda,
Nanda, you may be muted.
Push the mute button, Nada. You are, I think you are muted.
Call her on the cell.
yes, I'm calling, yes. Yes, hi. Are you muted? So I don't know what happened, because I cannot hear you.
Maybe go to the next one, and we'll come back to this one.
Yes,
okay?
yes. Okay.
Thank you.
Thanks. Let's go to the next presentation. We'll come back to Nada. Rupa from Mount Sinai West with Dr. Ekukar. You share your screen, please? Yeah. Okay, thank you.
Rupa, we can't hear
Can you
you.
hear me? Can you hear me?
Now we can hear you.
Okay. Okay. Good morning, everyone, and thank you for inviting me to present. So this case presentation is a 57-year-old man that presented to Mount Sinai West Emergency Department complaining of chest pain radiating to his back. He described the chest pain as sharp and throbbing in nature and rated it a 7 out of 10 with no aggravating or relieving factors. Patient noted the night before presentation to the ED, he had 1 episode of fever, chills, nausea, non-bloody, non-bilious vomiting with abdominal pain. His initial vital signs were pertinent for being hypertensive with initial BP of 246/126, tachypnic with respiration rate of 25, and oxygen saturation of 93% on room air. His past history is pertinent for hypertension, and he's a current daily smoker. He works as a parking attendant and performed all activities of daily living. He's compliant with all his medication, and he takes amlodipine and benazepril and Nexium. His initial exam is remarkable for being diaphoretic and severe distress and tachypnea. The remainder of the physical exam was within normal limits. The presenting EKG shows normal sinus and LVH with repolarization abnormalities. Initial laboratory results are pertinent for elevated white count with left shift. The remainder of the initial labs, including troponins, were within normal limits. Given the patient's severe hypertension and clinical scenario, there was concern for aortic dissection. A decision was made by the ED physicians to obtain stat CTA. The differential diagnosis given the patient's presentation included large vessel vasculitis, aortitis, acute coronary syndrome, pulmonary embolism, and severe COVID pneumonia. These are the CTAs that were done in the ED.
Thank you. Adam, if you wouldn't mind commenting.
Yes, please.
Did somebody say me?
Yeah.
Sorry. Okay, so on the on the image to the left, we see diffuse wall thickening of the aorta, which has its own differential, which could include an aortitis and could include an intramural hematoma or even large non-calcified thrombus. So the best way to figure out the difference would be with a non-contrast CT. But based on what I'm seeing, this would be too much for non-calcified plaque, and the rest of the vessels look pretty decent. So I would be very suspicious for an intramural hematoma at this point.
Can you comment on a double rule out and a triple rule out, how the protocol differs? Because you can use it for PE, dissection, and coronary CTA with one-stop shopping. So how is the protocol different, and how much more dye does it entail?
So in a case, in general, a double rule out we do on almost every case. So looking at the coronaries and the aorta is no issue. Doing a triple rule out, looking at the pulmonary arteries in the left side it can be difficult. So typically we give more contrast, let's say 100 milliliters, and there are many different techniques, including using saline chaser to sort of opacify the right ventricle as you're timing for the left ventricle. It gets tricky. And most of the time we get a good job, but very often what we recommend is that you go with what you think is more likely to be present, so you get the best study. But we do it, and it can be done.
Thank you.
Thank you, Adam. Rupa, you can continue.
So these are just some still images showing the extent of intramural hematoma. In the emergency department, patient was started on esmolol and nitroglycerin drip, and the SVP improved to the 170s. With control of the BP, patient's chest pain improved. Patient was stabilized and admitted to the Mount Sinai West ICU. Patient was subsequently transferred to the Mount Sinai Morningside CT ICU for further management of hypertensive emergency with type B aortic intramural hematoma. Labs were significant for COVID-19 detection and elevated inflammatory markers. In the CT-ICU, patient was started on labetalol and cardine drip for blood pressure and control, and slowly transitioned to appropriate oral BP medication. Transthoracic Echocardiogram done showed normal function with LVH, aortic root size, and no aortic regurgitation. Given the patient was COVID-19 positive, decision with vascular surgery was made to medically manage patient. After 2 days of BP control and no chest pain, patient went for repeat CTA to determine stability and further management. And this is what was seen on repeat CTA.
Adam, if you can comment, please, on this.
Sure. So the amount of low density material surrounding the aorta looks like it's increased. And then on that still image, we can actually see the intimal tear, I believe. And you can see the blood sort of entering the wall. Yeah, you can see it a little bit on the sagittal. There you go. So that's essentially the pathophysiology of how the intramural hematoma is happening through a tear and bleeding into the wall. So that's a very nice depiction of it.
So you think that the hematoma got worse, is that right?
It got bigger.
Bigger, yeah. Okay, Rupa, if you can continue, please.
Great. So as Dr. Jacoby said, the repeat CTA showed an evolving intramural hematoma with intimal tears and increased size of hematoma. The next slide just shows a comparison. On the left, you see the initial CT with, and on the right, you see, as you can see, the hematoma is expanding, and where the arrow is representing where the intimal tear. So further case clinical course, ID was consulted, and they determined that there was no indication for further treatment or management of COVID-19. Patient remained chest pain-free and medically stable. The decision was made to repeat a third CTA, which showed stability of intramural hematoma and no further increase of intimal tears. Given COVID-19 status and stability of third CTA, decision was made for control of blood pressure and referral to Dr. DeLuzzo for possible TVAR in outpatient setting. So some thoughts about discussion regarding this case. Given the current data showing relationship of ACS and stroke, could COVID-19 also be related to acute aortic syndrome? And is this intramural hematoma at all related to COVID-19? Also, has aortic syndrome in general been shown to be related to any other viral illnesses, inflammatory states, or pneumonias? And does the cytokine release in these patients pre-exist aortic pathologies and make patients vulnerable for rapid degradation resulting in acute aortic syndrome? So some data, just a quick review of just our aortic dissection. We're all aware of the DeBakey classification for acute aortic dissection. It divides dissections into type 1, which involves ascending and descending aorta, type 2 involving only the ascending aorta, and type 3 involves descending aorta after the origin of the left subclavian artery. For the fellows in the group, acute aortic syndrome also encompasses more than aortic dissection, which we don't always talk about, but it also encompasses acute aortic dissection, intramural hematoma, and penetrating aortic ulcer as depicted in the right image. So some data that I found regarding the thoughts and discussions. We have to ask the question, has there been any observational studies in acute aortic syndrome and COVID-19? There is limited data as of now, but a case study published last month out of Michigan discussed a middle-aged man with no risk factors for aortic aneurysm or acute aortic syndrome and no COVID symptoms, presented with acute onset of chest pain and found to have acute type A aortic dissection, which was emergently repaired. Subsequently, patient was found to be COVID-19 positive within 48 hours of admission, which begs the question if aortic dissection is related to COVID-19 in his infection. Next, we must question, is it possible for acute aortic syndrome in the person with COVID-19 to be related to vasculitis? Reports have shown COVID-19 infection can show signs of small blood vessel occlusions and vasculitis, such as petechiae or bruising. However, no reports of large vessel vasculitis attributed to COVID-19 were found on cursory search. an article out of Italy last month that discussed those with pre-existing large vessel vasculitis who had contracted COVID-19, and no results. There is no effect of COVID-19 on their large vessel vasculitis, but this was a single site study. Finally, we must ask, can acute aortic syndrome be the result of a high inflammatory and/or infectious state? There's no significant studies or case reports in general that have been published linking viral infection or inflammation with acute aortic syndrome. An article from 2015 from Italy discussed how infective aortitis can mimic acute aortic syndrome, and aortitis should be considered a differential diagnosis in those presenting with acute aortic syndrome type symptoms, as well as having fever and increased inflammatory markers. Wrapping up and returning back to our discussion points, current data is showing COVID-19 to ACS and stroke. Could COVID-19 be related to the acute aortic syndrome, and more specifically, this intramural hematoma? It's possible, but unclear. Clearly, this patient had elevated blood pressure. However, clinical presentation of sudden deterioration raises questions about the virus as a contributing factor. Has acute aortic syndrome been shown to be related to any other viral illnesses or inflammatory states or pneumonia? And as I stated earlier, there's no known studies that clearly tie the acute aortic syndrome to viral illness. And finally, does the cytokine release in those patients with pre-existing aortic pathologies make patients vulnerable for rapid degradation, resulting in acute aortic syndrome? There is no clear link for this, but further studies are necessary. Thank you, and we'd love your thoughts on anything.
Thank you, Rupa. I just want to thank Rupa. Rupa is actually post-nights. I really appreciate you doing this presentation. I actually have Dr. DeLuoso who's having trouble logging in. He's on speaker with me. He's the head of aortic surgery up at St. Luke's, and he was involved in this case. I didn't know if he wanted to make any comments.
Yeah, good morning. So I think, this is a great presentation. I can log on. I don't know if anyone can hear me. But essentially, he had the clinical syndrome of an aortic dissection for, the hypertensive crisis. That would obviously put him at a high risk for a aortic injury and aortic syndrome, and the IMH that he developed. And what he also progressed to a typical, type B dissection, where you start seeing the intimal tears in subsequent imaging studies. And there's a lot of theories on how IMHs begin, if it's a micro tear in the intima versus bleeding from the adventitia inwards. There's a lot of theories about that. And he was a classic sort of imaging finding of IMH progressing to small intimal tear. And then we'll see in the next couple of weeks when we image him again what that looks like. The reason not to progress, we were thinking of an endovascular repair or to remodel, or like the new word in aortic dissection is remodeling the aorta in the acute setting. It's because we were a little bit concerned about the progression of the hematoma. However, his pulmonary findings on the CAT scan were changing a bit, and given his COVID status, we were a bit timid about taking him to the operating room or the endovascular suite and intubating him for a procedure. And we didn't know how that was going to impact his overall progression of his COVID. So we're going to keep a close eye on him. We'll see him in 2 weeks for another follow-up CAT scan, and then decide how he's doing overall from the COVID, and then potentially go on to an endovascular repair. There is data from UPenn that looked at outcomes for early TVAR in type B dissection. It also looks like waiting 2 weeks in these patients have better outcomes from the standpoint of less peripheral vascular injuries and iliac injuries. from the large devices going in if you do wait 2 weeks. So we do have, obviously, data to support our decision to hold on intervention.
Thank you.
Thank you. Thank you very much.
Can I ask Marty Goldman, can I ask a question, particularly on the imaging? Because CT's static and not dynamic, why are you calling it a hematoma and not a routine dissection? Because you don't have the dynamic nature, you're just classifying it as a hematoma?
I mean, I would call this a hematoma more than anything based on the fact that you don't really see a false lumen.
But you have two lumina, you have the true lumen and the false lumen, but you're not seeing the intimal flap because you don't have the dynamic imaging.
I'm not sure if we have a false lumen. I think all of that low density material is blood in the wall.
Don't you get that with dissection, with dynamic dissection? I'm just asking the technical differentiation between hematoma and dissection. Are they interchangeable on CT? Because by echo, if you see flow, that would be a dissection. If you see static two chambers without intimal flap whipping back and forth without flow in, you would say that's a hematoma. And a dissection, because it's dynamic, it can dissect retrograde, so you can, the dynamic nature of it is very important.
Yeah, so I can.
Yeah,
go ahead, Adam. Oh, no, so I was just going to say that, I mean, it's not 100% certain. I think the reasons that we suspect or that this looks like a thrombus first is you don't see any contrast at all, which it could be a thrombose false lumen, but if it's acute, you wouldn't expect it to be thrombosed so quickly. The other thing is that it has a very typical crescent shape. So in a dissection, you will typically see more like a yin-yang type of pattern, but this one looks very, very crescent surrounding the aorta. But it's not 100%, but that's I think the two main reasons that it would look more like an IMH.
So that because there was you didn't see any dye going in to the other lumen, there was no flow.
Correct. I mean, ideally, or in theory, it could happen maybe a few seconds later. So if you do a delayed imaging, you might see it, but it's very unlikely.
Okay. And then if this patient was not COVID, because of the expansion, would that have qualified him to be operated on in a non-COVID era?
I think, that's Dr. DeLuoso. Go ahead.
Yeah, I think we would have definitely, we would have at least went on to an endovascular repair. We were just worried about the imaging of his lungs that looked and was commented on the final report that there was more acute lung injury on the imaging. Now, from a clinical standpoint, he was okay. We didn't really, of course, there's a lot of questions in COVID. We didn't know what putting him through a stress of a procedure was going to do to his COVID progression. So we decided not to proceed at this time, but to, follow him carefully.
Can you just comment on endovascular repair versus open repair results for dissections or hematomas?
Sure. So, when you open in the acute type B, dissection are not very good results. You have high mortality in the range of 25 to 30%. There's higher risk of paraplegia because these patients become very unstable and very unstable perfusion to their spinal cord after replacing the descending thoracic aorta. Overall, much more morbidity compared to the endovascular, which you're covering the intimal tear and then limiting the amount of flow that goes into the false channel. It becomes tricky when you have multiple tear because you will have occasionally a retrograde flow come up the false channel despite putting a device in the proximal thing covering what you think is the largest intimal tear. remodeling of the aorta with just a TEVAR. And again, the overall outcomes with TEVAR in the setting of a type B dissection are very good, with a mortality of 1 to 2% and a very, very low paraplegia rate.
Gabe, Eric Stern here. The comment of the TEVAR versus open surgery for people with classic dissection and similar aortic disease versus aortitis. Is there an issue of how that handles, what the tissue is like, and which one you would prefer if you had to do something? And then the flip side of that is, can we tell by imaging? That's not for you, that's for the others. Yeah,
definitely aortitis would be a bit better to operate on than the acute type B, or any dissection are like wet tissue paper when you're operating on a dissection. The aortitis are just a bit better. There's some chronicity to the aortitis in most cases that I've operated on, so the tissue is a bit better to operate on. In the infected aortitis, is a toss-up. You have to look at the overall patient, young, what the organism is, and it be treated medically, and then put in a prosthesis to control the possibility of rupture, and then bridge them to an open procedure at a later date when you've provided them with a course of antibiotics. So I think in general, today as we speak, the descending aorta in the acute injuries usually offer an endovascular repair just because the immediate results are so much better than open, and then decide at a later date if the patient needs an open procedure when the acute problem has been cared for with the prosthesis.
Thank you.
Thank you. Thank you very much. Dr. Coleman, you think we'll have time? I mean, we have only 5 minutes and there are cases.
If you think you can do one more quickly.
Okay. Okay, so we move back to Mount Sinai, Queens. Saban.
Okay, can you hear me?
Yes.
Thank you.
Okay, perfect. Sorry about before. Let me just, my case is quick, so we should be okay for time. Okay, can you see my slide and hear me okay?
Yes. Excellent, thank you.
So my case is a 20-year-old male with only past medical history of obesity, and he was also diagnosed with prediabetes during the admission. He presented to Mount Sinai, Queens, April 16 with symptoms of cough, hemoptysis, pleuritic chest pain, and upper back pain. Of note, he recently presented to an outside hospital and was diagnosed with COVID-19 3 days prior to coming to us, and he was recovering on oxygen at a nursing facility. At the nursing facility, he was taking only Tylenol and subcutaneous heparin, and unfortunately, from looking through the records, it was not clear whether the subcutaneous heparin was prophylactic or therapeutic, but he was taking at least prophylactic heparin at the nursing facility. On exam at our emergency room, his blood pressure was stable, 100/68. He was tachycardic at 141, low-grade fever, respiratory rate of 18, and his saturations were 98% on room air. The rest of the physical exam was unremarkable. To note his pertinent labs, his white cell count was 16, normal renal function, slightly elevated APTT, elevated INR, D-dimer was elevated throughout the hospitalization. Fibrinogen was 826, also elevated. Troponin and BNP remained within normal. Ferritin was high, interleukin-6 was high, and CRP was also high. This was his presenting EKG, significant for sinus tachycardia. I may also be able to convince you that he has a S1Q3T3 pattern here, but no ischemic changes or anything else notable. He, high up on the differential was a pulmonary embolism, given his presentation of hemoptysis and COVID positive. So a CTA was performed in the emergency room, and we can see here a moderate amount of thrombus burden in the right segmental and subsegmental lung arteries. Also, a small right pleural effusion. And moderate to severe findings on his lungs for viral pneumonia, consistent with what we see with COVID pneumonia. So he had an echocardiogram performed shortly thereafter, mainly to look for right heart strain for further management of the pulmonary embolism. On the parasternal long axis view, we can see that LV function appears normal, and RV5, at least here on this view, looks normal. On the short axis view, again, LV function is normal, no wall motion abnormalities, and there isn't any D-shaped septum or signs of right heart strain here either. On the apical four-chamber view, the RV size may be a little bit enlarged, although this is a slightly off-axis image, but overall function appears normal. Due to his body habitus, echocardiographic windows were difficult, so endocardial definition was not great. So the decision was made to use echo contrast. We used Definity, and on initial injection of the Definity, we see here a highly mobile circular echo density at the right ventricular apex. It's a closer up image of that. It measured 2 centimeters by 2 centimeters. So he was hemodynamically stable and admitted to the medical floor for further management of his COVID and of this pulmonary embolism. He was started on therapeutic Lovenox. The pulmonary embolism team at Mount Sinai Hospital was consulted, and they deemed that he was not a candidate for surgical intervention or for thrombolytics. A repeat transthoracic echocardiogram, day 7 of admission, showed no change from previous, with the residual RV mass still there. The patient was hospitalized for approximately 2 weeks and discharged home on Eliquis in stable condition. He remained in the hospital for a long time because of O2 requirements that his insurance wouldn't pay for to go home. So that's the case. In the interest of time, I'll just summarize quickly a quick discussion. Throughout this pandemic, I think we all noticed that there was a significant increase in cases that we saw with thrombosis and embolism. We saw that COVID-19 induced infection can be associated with a coagulopathy that we didn't really see with other viral infections, including influenza. The initial coagulopathy of COVID-19 presents with prominent elevation of D-dimer and fibrinogen and fibrin levels, while abnormalities in PT, PTT, and platelet counts are relatively uncommon in the initial presentation. Certain studies have found the frequency of PE to be approximately 2 times higher than in control groups, and reported incidence in differing studies was about 20 to 25% of cases coming in with COVID positive. And this also, we have to know that this might be higher due to lack of testing. Interestingly, incidence of DVT was not found to be as high, suggesting pulmonary thrombosis rather than embolism as the cause for this. And also, many patients would develop PE while receiving VTE prophylaxis. So the different societies for hematology and thrombosis have put out guidelines, as mentioned with our first presenter, for guidelines for giving anticoagulation to these patients. And I just want to note that they do mention that all patients with COVID-19 who are started on empiric therapeutic anticoagulation for presumed or documented PE should be given a minimum of 3 months post-discharge on this therapeutic regimen. This was mentioned earlier, but Dr. Lala and Dr. Fuster and colleagues also did a study at MSH showing that anticoagulation, patients who received anticoagulation who are mechanically ventilated had a higher survival probability than those who did not. And I'll open up the discussion. I know we're short on time. Thank you.
Thank you, Dr. Saban. Great case. And this again illustrates how prothrombotic is the COVID-19, and also shows again the power of echo contrast on the four-chamber view. Without contrast, actually, you was not able to see any thrombus, and then immediately you see that it's thrombus. Also, you can make the diagnosis because no perfusion. So important to use echo appropriately, as Dr. Goldman stated earlier. We'll take some questions for the interest of time. Dr. Goldman, any comments?
Oh, really, you know, excellent case. The question is, what was the source of the thrombus? Was it in situ, do you think? Did it come from the legs? Where did that thrombus in the right ventricle come from? And if it were non-COVID days, would there have been a more aggressive approach? Because if that were to move and block off the right ventricular outflow tract, there'd be no cardiac output.
Yes, absolutely. Unfortunately, he did not have lower extremity Dopplers performed, so we don't know. But we had definitely had the same questions when looking at this case. Again, like it's interesting that they mentioned that this could be pulmonary thrombosis or in situ thrombosis, and especially in COVID-19, making it less likely that it's embolism. Now he is also obese, but he is young, so you know we were very surprised to find this.
So I think it would have been interesting to do the ultrasound of the upper extremity as well as the lower extremity, especially
yes,
with
absolutely.
people being at home. I don't know whether Dr. Olin or Dr. Halpern or Dr. Fuster want to comment on the case and the case management and the anticoagulation protocols that have been written.
No, nothing from me, Dr. Fuster, if you would like on the protocol that was developed. I mean, we know the thrombogenicity is a very important component. We really don't know how to determine whether the problem in an individual case is embolic, in situ, or a combination of both.
Thank you. Thank you very much. I think it was great presentations, and I want to apologize to Dr. Danilov and Dr. Arkonak from the Mount Sinai BI, who had a ready case to present. And when we do this again, if Dr. Goldman give us another opportunity, there will be first, as Dr. Praya did today, first time.
Again, Dr. Lerakis, I want to thank you. I think these Zoom allow all of Mount Sinai Heart to get together and learn together, and you put together all the different places. So thank you for your efforts. Really was a wonderful conference. Thank you very much. Everyone have a great day.